And thank you for joining us today for our first Opioid Documents in Action webinar, a Q&A discussion with Christopher K. Haddock and Andrew Kolodny about their research team's recently published article on opioid marketing to veterans. Please note this webinar will be recorded. Links to the recording will be posted on our website and shared to our email list. I'm Dan Cabela, a postdoctoral fellow with OIDA at the University of California, San Francisco's Center for Tobacco Control Research and Education, and we'll be moderating this conversation today. The Opioid Industry Documents Archive, or OIDA, is a groundbreaking digital archive of more than 5 million documents arising from the opioid industry that advances understanding of the root causes of the epidemic and helps address corporate behavior that is harmful to public health. Winner of the Society of American Archivists Archival Innovation Award and co-created by the University of California, San Francisco and Johns Hopkins University, the archive serves as a living repository of information that can be used to learn from the opioid epidemic so as to improve and safeguard public policy and public health, and to ensure that the opioid-related harms that have taken place never occur again. OIDA was created and funded in part through settlements of public interest lawsuits by states, and we would like to acknowledge the millions of Americans who have been personally impacted by the crisis, as well as to recognize the attorneys general and many other parties whose vision and commitment to transparency and accountability has made the archive possible. We strive to ensure that OIDA serves as a trusted source of information to help people understand the U.S. opioid crisis. We are developing this digital archive and its supporting resources for the benefit of the public, including individuals, communities, researchers, journalists, policymakers, and others affected by the crisis. OIDA and its services are freely available to all. Indeed, there are many stories to tell about the OIDA documents, from marketing tactics to abatement strategies to policymakers and much more. We expect the archive to support research looking back at the crisis and helping to formulate systematic change to prevent future harms to public health. To that end, the OIDA team is creating a number of resources to help with further exploration, teaching, and mining the archive. For example, this past year we introduced an opioid crisis timeline, a curriculum library, an OIDA data toolbox, the OIDA image collection, and redesigned a website. These resources provide archive visitors with footholds and tools for research, data analysis, and other forms of exploration and discovery. We're glad to welcome our speakers today, Christopher Keith Haddock and Andrew Kolodny. Dr. Haddock holds a leadership roles as the Chief Scientific Officer of the National Development and Research Institute and as President and Chief Data and Analysis Officer of the Social Sciences Innovation Corporation, with offices in New York, and Leawood, Kansas. Since 2008, he has also been a co-owner and senior consultant of the Hope Health Research Institute. His expertise is further enhanced by a postdoctoral fellowship in clinical health psychology with the U.S. Air Force and in cardiovascular health with the American Hospital Association's Health Forum. A decorated military veteran who served on active duty and as an active reserve officer in the U.S. Air Force, his military background informs his research on populations such as first responders and veterans. Next, we have Dr. Andrew Kolodny, who is a medical director of the Opioid Policy Research Collaborative at Brandeis University and serves as the president of Physicians for Responsible Opioid Prescribing. He has played a key role in investigations of the opioid industry conducted by U.S. congressional committees, the Department of Justice, and State Attorney General. Dr. Kolodny has served as an expert witness in litigation brought by state governments against opioid manufacturers and was a medical advisor for the Hulu series Dopesick. Earlier in his career, he was the chair of psychiatry at Maimonides Medical Center in New York city. And so now I'm going to turn it over to Doctors Haddock and Kolodny so they can share their presentation about this publication.
There. Can everyone see what I see?
We're working on it.
Okay.
It's always that lag time of the screen
Yeah.
share.
How about now?
We're still on. There we are.
There we are. Okay. Thank you. It's a true honor to be here. In a group like this, it's easy to have imposter syndrome. I admire many the people who are here and really would prefer to sit back and listen to them. But what I will present today before Dr. Kolodny speaks is an overview of a paper that we just wrote. Hang on for a second. Using the OIDA documents. But first of all, let me give you some little background. Why are we doing this at all? Let me give you a little background on me. Why would I be interested in this? I am a military veteran. That's me sitting there in front of a B2 with, at that time, my son. He's now 30 years old and a software engineer, so he's much bigger than now. Like Dan said, I have a background I went to grad school twice, once in clinical psychology and then in statistics and data science, which led me to this area. I was involved in two NIH-sponsored studies of how the tobacco industry targeted military personnel. I did both of those studies with Ruth Malone at UCSF. Those of you at UCSF probably are familiar with Ruth Malone. She's also the editor-in-chief of Tobacco Control. And that's where I learned about document research. I actually learned it from her. My only pain experience, I am not an opioid expert. I rely on Andrew and other people on the team for that, but I was a provider in a chronic pain program at a military treatment facility, was a clinical psychologist for the people going through that program, and a close friend and colleague who is a co-investigator on this study is a chronic pain patient in the VA. I served in the military with him. He was severely injured in the military and he's 100% disabled today and receives his treatment at the VA. He is actually the one that suggested we do this study. He said, hey, remember what we did with the tobacco industry documents and with the tobacco industry influence on the military? He said, hey, UCSF and Johns Hopkins have this database of opioid documents. And so we ran with that. We linked with the people on this board here. You can see our team. And we eventually were able to get NIDA grant funded. NIDA also funded our research on tobacco industry influence on the U.S. military. They've been wonderful, both as advisors and as funders. But the grant is called The Impact of Pharmaceutical Industry Messaging on the Opioid Crisis Among U.S. Military Veterans. And you can see the documents are part of a sub-aim. It's a much bigger project than that. We're not just looking at the documents, but you can see the sub-aim is to look in the documents and see how or if and how the pharmaceutical industry targeted veterans. As a military veteran, we're often targeted for bad things. There's just a long list of those things. So it was no surprise that we found that the industry targeted us too. Lots of expertise on here. I don't know if you know Jennifer Olivia. She's heavily involved in litigation research, Dr. Kolodny, and we have two of the primary people that deal with opioids in the Veteran Health Administration on our team. So it's a great team to work with. Our inaugural paper, the first paper we came out, we're working on papers in a number of areas, both in the documents and supplementary to the documents, was a paper on a Janssen-sponsored group called the Imagine the Possibilities Pain Coalition. Janssen, I believe, is owned by Johnson & Johnson, and they created a group to target veterans. Now, I would encourage you to download that article and read it because I'm not going to go into a lot of detail. I assume you can read the article yourself. I also encourage you to read an article that I cite at the end of the introduction by Yakubi. His team published two articles on Imagine the Possibility Pain Coalition. They're more general, and our contribution was to really drill down and focus on how this coalition targeted veterans. So for the background of the article, this is not anything that will surprise any of you, is the veterans really carried a disproportionate burden of chronic pain and opioid addiction, opioid risk. Um, During the height of opioid prescriptions, veterans face overdose mortality rates that were, I believe, double those of the general population. Um, all these harms resulted in over $50 billion in settlements, as you know, which is the reason we have the documents. And the legal basis of those settlements was that the industry had aggressive opioid marketing in the 1990s and early 2000s that amplified prescribing, maximized prescribing, and resulted in harm. The policy context is those large settlements, the fact that we have these documents, and also real rapid changes in how the VA deals with opioid therapy. We were doing a paper on the original guideline for the management of opioid therapy by the VA. It was in 2003. If you read that document and read the guideline today, it's very, very different. In fact, we've been able to interview about half of the panel that wrote the 2003 guideline, and we'll be publishing a paper on that. So, the study purpose and methods, just to let you know how we dealt with the documents and how we came up with the what we did. So we wanted to, of course, the aim was to examine Janssen's Imagine the Possibilities Pain Coalition to see how it sought to shape pain narratives for veterans. We developed a large corpus at first of documents from the archive that referenced the military or veterans. So we used, it's essentially, we use keyword text strings to come up with, to find all the documents that reference military and veterans. We use delimiters too. We didn't want documents that just refer to Veterans Day or Veterans Drive, that sort of thing. And we amassed over 60,000 documents within the database at the time that we looked at it. And all these reference the military or veterans. And among those documents, so how we looked for documents that were relevant to the Imagine the Possibilities Pain Coalition is by using an AI platform called CoCounsel. I probably should explain to you a little bit about CoCounsel. It's now owned by Thomson Reuters. When we first started working with CoCounsel, it was a startup. I watched a TED Talk where one of the founders of Casetext, as it was called at the time, talk about their product and how it would revolutionize legal research, and it really has since then. Many large legal firms now use CoCounsel to look through and triage their documents of discovery. And I was fortunate to be able to meet and become friends with who is the person who's now the vice president of the CoCounsel at Thomson Reuters. His name is Pablo Arredondo. And Pablo was the CIO of Casetext at the time, became very interested in working with us, has never charged us a dime for his advice to us and working with us. And using this platform, we were able to triage documents and come up with the ones that were most relevant to this topic. We say we used a human in the loop approach. People always worry about things like hallucinations. We actually physically read every document that we used, and the qualitative data that we present in the paper are really the result of the humans. It's more the triage that that CoCounsel helped us with. We are in the process now of developing our own platform for that using the API port key. So we have brought on some AI engineers, and we want to develop a platform to use with the documents specific for researchers that allows for really the ability to really reproduce workflows for journal articles, that sort of thing. So that's what we're in the process of doing now. So what was the Imagine the Possibilities Pain Coalition? I have a little piece of one of the documents there in Figure 1, but it was a Janssen-backed coalition, as we said. It was launched in 2001. You can look through the documents and see the planning, the initial emails, and the meeting notes from this group. It's really interesting to look at if you wanted to look at them yourself. It officially launched in July of 2011. It initially had 19 members of the coalition. 9 were from Janssen, 6 were from industries aligned with Janssen, and 4 were from academia. Launching in 2011 was a little bit unfortunate for them. As you probably know, that's when people started, at least the CDC started referring to the opioid crisis as an epidemic. So they were really dealing with that, the fact that in the background there was an epidemic going on, or it was being framed as an epidemic. And our analysis of their marketing messages was that it encouraged a focus on chronic pain patients' current pain symptoms and away from addiction or long-term functioning. So they were really trying to go after the phrase epidemic of addiction and replace it with the epidemic of pain. And they say that explicitly several times. So the theme in their words of this coalition was that the problem of poorly managed pain is often lost to the topic of fear of addiction, even though it is an issue of many magnitudes of importance. So that was the purpose of the coalition, was combat fears about addiction, fears about negative outcomes, and encourage the use of opioids. These are the key tactics you can see in the paper that we identified that they used. Most of them won't be a surprise to you. They're kind of the playbook. Many of these tactics we uncovered with the tobacco industry too. I guess there's so many things you can do in this area, and they all do them. One is to produce education materials that minimize addiction risk and overstated long-term benefits. A big part of it was a empathy forward message, getting physicians to focus on the fact that the person in front of them has acute pain, has pain right now, and that their primary task is to solve the pain problem right now. So it was to try to remove the focus from anything beyond right now in the office, anything in the future, and to minimize pain right now. They also use ghostwriting, as many groups did. They would have groups ghostwrite a paper, seek out academics to be authors on that paper, and that paper would either subtly or explicitly have a marketing message in it, favorable messages to the company. And the other thing that was a real big feature of Imagine the Possibilities campaign toward veterans is the thought that risk stratification would undo harm, that we know basically which patients will become addicted to opioids, and even those who do can be managed in the long term. So that was really the purpose of the coalition and how they operated. In the paper, we review one of their products, and that was a publication. And if you remember back to what their mission was, one of their mission was is to get publications in the literature that were favorable to their company. And so this paper was published by the Imagine Possibilities Pain Coalition, and it was called Pain Management Strategies and Lessons from the Military Narrative Review. Earlier drafts, so one of the things you can do in the document archives is you can see the evolution of this paper from the time of its inception to really, you stop hearing about it after it was first submitted to a journal. Pain Research Management was not the first journal they sent it to. I didn't see anything about this specific journal or how many journals they sent it to before it was accepted, but eventually it was accepted in this journal. You can see that, or on the slide there, you can see that one of the narrative review, really the purpose of the narrative review was that pain had been managed with opioids successfully in the military, that the military does good risk stratification, it does good post-therapy support for people who have problems with opioids. And so that is an example that the same thing can occur in the civilian world. The paper was really, it seems like, written by a media company called Metergy. If you just put a keyword search Metergy into the UCSF or Johns Hopkins, you'll see lots and lots of hits to that. That company was used a lot by pharmaceutical companies for writing papers based on opioids. And so the message of this paper was that opioids are critical in chronic pain and that any sort of problems can be easily managed. One of the things that really struck me about this paper was that it was, so Metergy seemed to have written it, but it said it tried to downplay that in the article. And this is true for a lot of articles that were put out by Metergy. For example, it said full editorial control was had by the authors. There's evidence in the archives that other articles that talked about having full editorial control by the authors. There's documents, emails showing that many times the authors had severe concerns about a paper, but it was submitted anyway, despite that. So it's really hard to know what editorial support means or how much the authors had control of it. The central message of this paper really was that long-term opioids have been successfully used for non-cancer chronic pain in the military, and thus applying this strategy to the general population will lead to improved outcomes. And they did this by showing A, that opioids were effective, B, that risks are minimal, and that any adverse effect can be managed by stratifying patients on risk factors or just managing them afterwards. So that was it. One of the things we do in the paper, if you go and read it, I won't go into detail about that, is we look at their claims, look at the citations that they give for those claims, and we show how there's really a disjunct between what they claim the citations prove and what they actually prove. Again, we're not the first group to criticize this paper. Yukubi does in their paper on different points, but this was the primary thing that this group put out before it had to disband because of the opioid crisis. So what are the implications for the VA and DoD? We talk about our whole discussion section is about that. We just encourage the VA and DoD to scrutinize industry-funded coalitions. A lot of people told us that they just assumed that the APF was an honest broker of information, and so they just accepted information from them. To prioritize evidence-based non-opioid first chronic pain care, which the VA is doing now, to promote manuscript transparency, treat editorial assistants as potential ghostwriting, and to be sure to align training guidelines, those sort of things, with current guidelines rather than marketing messages. So I will now turn it over to Dr. Clogney.
Thanks, Keith. I'm just going to make a couple of comments. Oh, Keith, can you leave that last slide up?
Yeah, sorry about that. I'm not sure what
That's
happened.
okay. So I'm just going to make thank you, a couple of comments before we open it up to the panel discussion. I want to provide you with an overview of where we were at the time that the Imagine the Pain Possibilities Coalition was launched by Johnson & Johnson in 2011. What you're looking at here is what was going on at that time. This is came off again. This is a CDC slide, and it's an old slide. The CDC came out with this slide to send a message to the medical community, really, that we were massively overprescribing and that the rise in the prescribing was fueling a public health crisis. And so what you see on this graph in green is sales for prescription opioids. In red, you see prescription opioid deaths. And in blue, you see prescription opioid addiction measured by treatment admissions. And so the CDC's message really when it came out with this slide was that the green line needs to come down if we hope to bring this crisis under control. The opioid industry has never really agreed with the CDC on this. And I can tell you that when these three lines began going up together, initially the opioid industry was arguing that this wasn't happening. And in fact, they were paying scientists to publish articles saying that this isn't happening. One of the more famous articles was in JAMA in 2000. I think the first author was David Joranson, where the article actually said that sales are going up, doctors are prescribing more opioids, but there's no evidence of any adverse public health consequence. And even in 2000, when that paper came out, there was good evidence that the rise in prescribing was fueling a public health problem. Papers like that continued to come out until around 2004. By 2008, though, that message had changed. You were no longer hearing the opioid industry deny that these lines were going up together. Instead, you started to hear this messaging that Keith mentioned along the lines of risk stratification, that basically the idea was we still need more opioid prescribing. If anything, the green line should continue to go up because millions of people have have chronic pain, but we should teach doctors to more carefully select their patients using something like the opioid risk tool, which the idea was it would tell you someone's risk of getting addicted, and of course, there's no such thing as predicting in advance who will or will not get addicted. And that patients should be more closely monitored. And if you do these things, and if you make the pills harder to crush for snorting or injecting, so-called abuse deterrent formulations, then we can all have our cake and eat it too, and that green line can keep going up. So that was the environment in which Johnson & Johnson's pain division, Janssen, was introducing a new opioid called tapentadol is the molecule. The brand name is Nucynta. And so it's introducing Nucynta at a time when it's become pretty clear that we have a problem with prescription opioids. The CDC is calling this an epidemic. And they're interested in increasing sales. And so they went about creating the Imagine the Pain Possibilities Coalition. And I just want to mention a few items and why I think this topic is important. Really, the coalition that they created and this effort by Janssen illustrates three industry tactics. One is the use of key opinion leaders. And as Keith mentioned, in that coalition were some very prominent key opinion leaders, including a key opinion leader today who's quite prominent in kratom and working with the kratom industry to avoid regulation. And the second tactic was the creation of a front group. The Imagine the Pain Possibilities Coalition is not one of the more well-known front groups, like the American Pain Foundation, which was shut down on the day that the United States Senate launched an investigation. And there were other more prominent groups, but so it illustrates the use of front groups, and it illustrates also the use of medical education communication companies like Metergy. And if you're not familiar with that industry, it's an industry that generally works for pharmaceutical companies to help them get articles placed in the medical literature that will increase sales of products. And it's also an industry that helps pharmaceutical companies sponsor educational programs for healthcare professionals, like continuing medical education programs. And what I think is really important here is that these tactics that we're talking about, the creation of, in particular, the creation of front groups and the use of medical education communication companies to influence the medical literature, influence medical education programs. We've yet to really address these problems. And despite the opioid crisis being a very good example of what can go wrong when the pharmaceutical industry has undue influence on medical practice. These are industries that remain not adequately regulated to this day. And it really speaks to why the Opioid Industry Archive is so important and why research on these tactics is so important, because we really do have to address these regulatory failures that led to the opioid crisis. So I'll stop there and so we can open it up to discussion.
Great. Thank you, Andrew and Keith. This paper is certainly rich with insights into industry's role here. And so now we're going to turn it over to the forum discussion. And I prepared some questions, but we're glad to for audience members to share questions in the Zoom, as well as a Q&A feature as well. I wanted to open it up with a question. Here at the Tobacco Center, we are trained to identify industry tactics, and I was really drawn to this concept of Trojan horse marketing, which I understand is kind of initiative that appears as kind of patient-centered, but really serves the industry interest. And I'm wondering if you can expand on that, while also speaking to ways that oversight for these coalitions and educational offerings can be strengthened to prevent that kind of marketing?
Yeah, sure. I one of my part of my background is I have a degree in business analytics, and so as part of my data science training, and I didn't know what a Trojan horse marketing was until I took marketing analytics, and it was talked about quite a bit. And essentially, in Trojan horse marketing, what you do is you present a product with strategy and a seemingly beneficial or couched in a pro-social message, but you really have another goal. The goal isn't that pro-social message. The goal is something else. And this was a conceptual, I didn't find anything in the documents that said that they didn't use the word Trojan horse marketing. It was more, it looked like the way that they were doing things fit in the category that marketing professionals use called Trojan horse marketing. And and in this paper, really the example of that was the empathy forward messaging that, looking at the patient in pain, that who would argue with that? I mean, of course you would do that. Who would argue with empathy forward? Of course you would do that. As a veteran, probably half of my veteran friends struggle with pain mightily. And so, anything to help them relieve their pain. Of course, empathy forward, you would want to do that right there. But, what we said is that, in Trojan horse marketing, really the goal is to increase sales. So by downplaying evidence-based care, by emphasizing a patient's immediate subjective experience, it could potentially lead to, increased sales by doing that. So, that's the reason why I think they talked about, it's more than an epidemic of addiction. We have an epidemic of pain. Let's focus on the epidemic of pain because it's so much more important than the epidemic of addiction. Not considering that the epidemic of addiction also leads to pain. So, Andrew, anything?
No, nothing in particular to add to that. I thought that was, I would agree with you.
Great. Yeah, I think it's interesting when pain also becomes kind of closely tied to veterans' sense of self. You kind of mentioned that in this idea of empathy. Um, Let me turn to a few questions from the audience here. So one is, why did you use SciServer, and what is the value of using that rather than just downloading documents from the OIDA platform?
Yeah. Well, just one thing, just to clarify, SciServer is an OIDA platform. So all the documents that are on UCSF are also on the John Hopkins site. So you can do either. Um, I cut my teeth on the UCSF site because I worked with Ruth Malone at UCSF, and the DBACA documents were there. And the benefit of the SciServer platform is the ability to download large troves of data at once. So I could, that's not possible. At least it wasn't possible when I was writing this paper. The UCSF people can tell me if it is. You essentially download one at a time off the UCSF site. So it's really more of a download issue. If you put the same search string into the UCSF site that I used in the Python, so one of the downsides, it's not a downside for me, but one of the downsides of the John Hopkins site, you got to be roughly familiar with Python to be able to use it because it uses Python notebooks to do that. I had a little bit of a Python background, so I was able to do that. Kevin's team kickstarted that by providing me a Python notebook example of what to use. I only had to tweak it minorly because we were downloading a lot more than they conceived of. But and the benefit of that is rather than doing like snowball sampling, that's what we did with tobaccodomics, where you just keep reading until you feel like you have enough to support your case. We were able to triage every document that referred to any topic. We could download all the documents, even if it was tens of thousands, and look to see if there was anything relevant there by loading it into our LLM platform. So the benefit of the SciServer is that you can do bulk download, really. But you get the same documents using the same search string on both sides. And Kevin, if I misspoke there at all, I hope you'll jump in.
Great. All right, so the next question we have here is there any updates on what is going on with the opioid prescribing in the VA system today? How much have things improved? Are vets being overprescribed opioids right and left and center?
I will say something, then I'll let the person who actually knows tons more than me, Andrew, say something. But the VA has dramatically changed the prescribing practices. In fact, we've been interviewing lots and lots of chronic pain patients who are veterans, and they talk about how difficult it is now to get opioids in the VA. The VA really is, they see opioids as a secondary or tertiary approach under certain conditions, but definitely not a frontline therapy now. And the new guidelines that reflect that, they actually are coming out with more guidelines right now. Our team is working on, not me, but the VA folks on our grant are working on those guidelines that are coming out. Andrew, anything?
Sure. I'll echo what you said just a bit. The VA, I think, was probably among the worst, if not the worst, healthcare systems in the country when it came to opioid prescribing early on. The VA actually explicitly adopted the Pain the Fifth Vital Sign campaign and issued an opioid prescribing guideline in 2003, which is probably one of the worst opioid prescribing guidelines ever issued, and had programs where they actually took money from pharmaceutical companies to promote pain teams in VA systems. That had an impact. The prescribing of opioids within the VA system uh, skyrocketed. And if you look at that, if you remember that green line that I just showed you in my graph, that was national data. The rise in opioid prescribing within the VA system was even greater. That slope was even steeper. And it was so bad that by around 2012, the overdose death rate among veterans in the United States was twice the national average. And again, you have an understanding of how bad the national average is. It was even worse within the VA system. By around, I'd say 2006, 2017, actually, the VA had really made a U-turn and issued probably one of the best opioid prescribing guidelines in the country. I would say, in my opinion, even better than the CDC's guidelines, and has recently issued a few years ago, issued a more current version of that guideline. And so, yeah, I think that they are doing much better when it comes particularly to long-term use of opioids. They are still, we have a generation of veterans now who were overexposed to opioids, and that the VA is dealing with the consequences of that. I do think there's likely room for improvement still, both within the VA and in healthcare systems, particularly hospitals across the country. We are still prescribing opioids too aggressively for acute pain, both while they're in a hospital bed and on discharge. And I think we could be doing a lot better on that front. And I think there is still room for improvement there within the VA system.
Great, thank you. And somewhat of a related question, but bringing us back to the documents, and this is a bit broad, so you can take it where you want. But are there unanswered questions about veterans that you believe can be answered through further use of OIDA documents?
Yeah, obviously, NIDA will expect more than one pub from us. So we're actually we're actually working on a lot of, the things that we're working on. Just to let you know, kind of the broader context. We are working on papers on the other coalitions and organized attempts to influence the VA or veterans. But we're also looking at. So we've interviewed a lot of veterans, and we're looking at common cognitive scripts that have driven attitudes about opioids and chronic pain. Um, two of them that I can talk to you about that we are working on. One is opioid therapy as a right, that veterans have served their country. We've risked our lives. We've done much more dangerous things in our career than take opioids. And so therefore, if we think that we need opioids and we've had good experience with opioids in the past, we should not be denied opioids. So that's one. And opioids as a right was developed, that cognitive script that a person has a right to access something, even though somebody's risking their license to give you that. That is a cognitive script that was intentionally developed. And the other that we're working on is on medical gaslighting. And a lot of the things in the documents you'll see talking about gold standard treatments, pseudo addiction, those sort of things were designed to say that the gold standard treatment for chronic pain is opioids. That was what was explicitly said in the Valorant article that we covered, and that all the other treatments, if a physician is trying to get you to try other treatments, that's medical gaslighting. They think you're crazy. So why wouldn't they give you the gold standard treatment? I mean, it clearly is. And so there's lots of themes like that became cognitive scripts in veterans' minds. I mean, I'll be honest with you, Dan, some of them were in my mind when I was in the military. Um, that those cognitive scripts are in there, and then the influences on the VA itself, like the fifth vital sign. We are doing a lot of work. Our VA group is doing a lot of work on the fifth vital sign, both looking at policy changes in the VA and constructing timelines of who was pushing that. And a bit of a confession, when I worked in the chronic pain program, I went around giving talks to the hospital about the importance of the fifth vital sign. So um, I've come full circle myself. And
Great.
Andrew?
Yeah, I would just add just something for people to keep in mind, and maybe this is already known by most of the people on who are participating today. But what's in the archive is really the tip of an iceberg. So the documents are these are the source of these documents was the litigation where a manufacturer or really an opioid industry defendant in the litigation gets subpoenaed, or some third parties get subpoenaed and are required to turn over thousands or sometimes millions of documents that the lawyers, the attorney generals generally have will then go through to pick out the documents that will be useful in a trial. And so, for example, the Imagine the Pain Possibilities Coalition was something that came to public attention because in the trial against Johnson and Johnson, Janssen in Oklahoma, we found these documents. I testified about the coalition during trial, and because those documents were used in a trial, they're now available in the archive. Or if documents get attached to a motion, they can become unsealed. But the what's been unsealed is truly the tip of an iceberg. And so there's a lot more out there. And even what's available to attorneys in the litigation, so it's hard to find everything that you would be looking for. It's better than it's not like you're searching for a needle in a haystack because you can use search software. But it's still difficult to find all of the evidence that you might be looking for. So I think there is still much more to learn about how the opioid industry targeted the military and veterans. I think we're going to learn a lot more when Purdue's documents start to become unsealed, that there's a very large number of documents that may soon become public.
Yeah, I just wanted to add to that, Andrew, and you correct me if I'm wrong, but so I did a lot of work in the tobacco industry documents, and I'm sure some of the people on the call did too. And there was much less communication discipline among their employees than I think the pharmaceutical industry has. At least employees of companies like Johnson and Johnson, they have better lawyers, better training, and what to and not to put into emails. So I don't think that is going to be the case with some of the documents that will be downloaded in the future. I think there will be.
That is true. So you not only is it hard to find good documents, but you're also often the industry knows better than to put things in writing. And Johnson and Johnson was especially good at being careful what they would put in writing. So for example, up until I can't remember the exact date, they were collecting notes from sales reps who were visiting doctors. And the reps were coming back with notes about how they told this or that doctor something that wasn't true. And I think J&J realized we shouldn't be collecting this in writing, and they took away sort of the free text fields from. But there's an understanding, and I think most people know you have to be careful what you put in an email these days. So in light of that, we still find serious evidence of wrongdoing.
Yeah. there's not as much low-hanging fruit there. I mean, the tobacco industry said things about veterans that were just openly appalling. Um, and it's harder to find things like, well, if if they die, that's a shorter amount of time you have to pay retirement. So you save money in the long run. I mean, there's not that kind of thing in there that were in the tobacco industry documents.
Great. So we're coming to the end, and we have quite a few questions here still. Everyone is very engaged in your work. So I'm just gonna, for a last question, kind of combine a few that I think are related. So Dr. Kolodny, you mentioned one of the forerunners supporting opioids is now doing the same for kratom. What similarities are you seeing in how kratom are being marketed or misrepresented to consumers compared to during the opioid crisis?
Yeah,
And second, oh, go ahead.
go ahead, please. I'm sorry.
Oh, sure, yeah. And the next one is kind of a similar question around this the psychedelic industry. How do you see similarities?
So on Kratom, it's pretty much use of the same playbook. You're seeing the medical literature influenced with articles that downplay the risks of Kratom. There are key opinion leaders out there who are giving talks. I haven't really investigated the industry. I don't know if one of the main individuals giving talks has a financial tie with the kratom industry, but I suspect it's possible. The messaging that you're getting right now is that 7-hydroxymetragenine bad, that's synthetic and is actually a financial threat to the kratom industry. But kratom good, 7-hydroxymetragenine bad, which 7-hydroxy is a metabolite of metragenine. So if you're consuming kratom, you're consuming 7-hydroxy just in maybe a lower concentration. And what I am seeing clinically is that the large majority of people who I'm treating who are newly developing opioid use disorder, it's through kratom. And one of the key players in this is an individual named Jack Henningfield from a company called Pinney Associates. Pinney Associates and Jack Henningfield were on that paper that Keith showed in the Imagine the Pain Coalition. Pinney Associates is an organization, a company that helped the opioid industry avoid regulations and is now working with the kratom industry. So the psychedelic industry, I haven't really looked into it. I do have some concerns, even the use of the term psychedelic, which I'm seeing apply to ketamine and MDMA, which are not psychedelics, and do have, particularly ketamine does have some addiction potential. It's a good medication for use in an OR or an emergency room. Outside of those settings, there are real risks that are also being downplayed by an industry.
Great. Well, thank you, both Keith and Andrew, for your time and for this wonderful work. And thank you all in the audience for being here today. This is a way that you can stay plugged in.
Thank you, Dan.
Thank you.